Hello, and welcome to the GoLIVE Health Foundation Health Equity Webinar Series. Thank you to all of the sponsors of our series. Today's episode is brought to you by our friends at ResMed. We would like to remind you that the Q&A feature will be available, so feel free to send in your questions for our speakers. And with that, I will turn over to our moderator, Renee Kwashi, who joins us from the Consumer Technology Association.
Thank you very much. I'm really looking forward to it. And what I'm going to do is I'm going to turn it over to each of the speakers to introduce themselves and tell us a little bit about what they do, their functions of their organizations, and then we'll get into our panel. So why don't we start off with Carlos?
Hi, thank you, Renee, and thank you for having me to the Health Foundation. My name is Carlos Nunez. I am the Chief Medical Officer of ResMed, and as such, I have the privilege of working with our medical affairs, our government affairs, and our market access teams to help patients around the world sleep better and breathe better.
Great. Meredith?
Great. Excellent to be with you today. Thank you for all the organizers. My name is Meredith Barrett. I'm the Vice President of Population Health Research with Propeller and ResMed, and I lead the Digital Health Insights team. So we're focusing on multiple areas of research pertaining to digital health, clinical outcomes, behavior science, population health, and implementation science. I have doctoral training in environmental health and postdoctoral training in population health, and have been working in digital health with Propeller for over a decade. And so that has provided a close view into the scaling process of digital health, including the barriers and the successes, as well as evidence generation process. So I'm excited for our conversation today.
Excellent. Jaron?
Hey, Renee, thank you. And thank you to Health, and thank you to ResMed and Propeller for having all of us here today. So my name is Robert Jaron. I just go by Jaron. I've been in the wireless health industry for close to a few decades. I am now a strategic advisor to a number of companies, associations, and medical organizations in the area of digital medicine and payment. I also serve as an advisor to the American Medical Association's Digital Medicine Payment Advisory Group, although I am not here representing AMA or the DIMPAG. Looking forward to the conversation. Thanks.
Great. As you can see, a tremendous panel. So I'm really looking forward to this discussion. But before we get into this discussion, I want to note a couple of things. First of all, the information provided in this session is not medical advice. It is the responsibility of individual patients and their providers to determine an appropriate course of treatment. The other thing I want to note is that the information provided in this session is not billing or reimbursement advice. No tool or technology guarantees reimbursement of submitted claims. There's a provider's responsibility to work with professional legal advisors to understand whether they can submit claims for remote therapeutic monitoring or any other code for that matter. So with that, let's get into our program. Oftentimes I find when we get into these panel sessions, we sort of tend to dive in right into the discussion without first providing background of the issues that we're actually going to be discussing. So I want to start with Meredith and ask you to give us a quick overview of disparities among older populations.
Sure. Yeah. So a health disparity is a preventable difference in a health outcome. It could be disease burden or diagnosis or quality of life. And they're closely linked with social, economic, or environmental disadvantage. And so for a number of different reasons, age can be one of those factors that can make a person more vulnerable to not being able to seek care or benefit from their care. And additionally, when you combine age with other factors that can increase vulnerability, perhaps disability, housing, socioeconomic status, literacy, race or ethnicity, gender, you can magnify those adverse outcomes. And you can actually see this accumulation of disadvantage over the life course. Age can make a person less mobile or have less money to spend on medications because they may be on a fixed or low income. They could feel less comfortable with technology or with the healthcare system in general, or have cognitive challenges. And I think another important one to note is that they can have more limited social interactions and social support networks. And that's very important when you're thinking about managing potentially very complex chronic conditions. And of course, this is not the case across the board. There are plenty of older adults that have means and tech sophistication and strong social networks. But when we look across the population level data, we do see the following trends in respiratory disease. So in asthma, we see older patients are more likely to be underdiagnosed, undertreated, and hospitalized than younger patients. In COPD, prevalence is 2 to 3 times higher in those over 60. And with advancing age, we also see increasing comorbidity. And so that, again, makes the treatment of a health condition more complex. And I think it's important to note this is an important conversation today, because by 2060, nearly 1 in 4 Americans will be 65 years and older. And so with this increasing number of adults, the country really could see increasing demands for healthcare, in-home caregiving, and assisted living facilities. And so I think that is, with those increasing needs for chronic disease management, we'll need to handle that with potentially limited staff and facility resources. So I think that's really what makes our conversation today so interesting. I see digital health as a critical part of that solution to help kind of bridge that gap. So enabling remote monitoring and intervention at the right time for patients who may be at home dealing with multiple chronic conditions.
So to pick up on your last point, how is adoption of remote monitoring tools for respiratory disease look for older populations so far?
Yeah, my first thought is to go to how have the last couple of years been with the pandemic, and obviously there's been a lot of talk about an increase in the use of telehealth. So, for example, among Medicare beneficiaries, the rates of telehealth service use has gone up quite dramatically from the previous year, but only a small portion of that has really been remote monitoring. So I think there's still a lot more to build there. That said, so we do surveys with our Propeller users, and we've gathered responses from hundreds of Propeller users with asthma and COPD, and we have seen an interest in a use of digital tools, including video visits, phone calls, provider messaging services, really in partnership with Propeller. And then we've also seen increasing adoption of at-home digital tools. So with the inhaler sensors, pulse oximeters, heart rate monitors, and spirometers to support remote monitoring. And in our surveys, the majority of patients reported finding that the use of remote care helpful. When we look at our Propeller specific data, we do see that older participants do really quite well. So for those using smartphones, we found that older patients actually engage more frequently with the app than younger. So twice as many older adults were engaging daily with the app than their younger counterparts. For participants without a smartphone, like some older adults, Propeller offers a wireless hub for the sensor connection and the data transmission. And so we've seen excellent retention in those programs as well. And I think it really points to this fact of the combination of technology, so the smartphone and the hubs and the sensors, along with that kind of clinical oversight involved with remote monitoring, is really a promising combination to achieve both higher retention as well as good clinical outcomes. And when set up properly with the right clinical workflows, can be an efficient way of monitoring patients.
That's phenomenal background. So I just want to shift a little bit. And Jaren, given your interests and your focus areas, it's clear there's been changes in the way Medicare approaches billing for remote monitoring. I think it would be useful if you could give us a quick history of how Medicare billing for remote monitoring.
Sure, you bet. So I like to go back and think of the time when telehealth really was, the prevailing service that CMS focused on. And when you think of telehealth, obviously it was regulated pretty heavily by CMS, but it really was born of, changes to the Social Security Act. In those changes, when they defined telehealth, they really, Congress didn't really get into what is a telecommunications system. So when you look at what CMS did with that definition, they really looked at it in a very arduous way. It had to be live voice and video modality. It can only happen in certain parts of the country. There had to be an originating site that was deemed by CMS. A lot of these things went through rulemaking and really became very, very specific that narrowed, through a number of requirements, narrowed how telehealth could be used around the country. I like to remember back a decade ago or so, that ATA had this great statistic where I think it was like 86% of the US landmass or something was disallowed from using telehealth services. So when you think about that history, something like remote monitoring, which is not live or video, it's really usually a passive modality that does not require voice or video. It didn't really fit. And for a number of years, the industry was trying to make headway with CMS, trying to get them to understand that, look, this doesn't really adequately fit in here. Which is important, because you have to think of how services are defined, really going down to how they're described, which gets into coding. But before I talk about coding, I think that the really big impetus on focusing on remote monitoring actually happened through the passage of MACRA, the Medicare Access Chip Reauthorization Act, back in 2015. I think it was April 16, 2015 to be exact. Within that act, there was a mandate, a requirement that Congress asked GAO to draft a report on the usage of telehealth and remote monitoring. And in that report, it was interesting and insightful that MedPAC actually had looked at this very issue and had said, look, CMS is spending money on remote monitoring, but it's really cardio-related remote monitoring, somewhere in the order of like $190 million for 900,000 beneficiaries just a year before. So this is something that CMS was spending money on. And this report actually came out in 2017. So fast forward, this is the beginning of 2017, sometime around April that year, later that year in July of 2017, CMS puts out its annual rulemaking, the physician fee schedule, where for the first time, they actually talk very specifically about remote monitoring, and they're looking to differentiate it. And they say, look, we're aware that these services are being provided. We would like to adequately describe these services. We have 2 existing codes, which may not really be remote monitoring, but we'd like to make payments available as soon as practicable. So they basically make a policy declaration in this proposed rule, and they say, look, remote patient monitoring services would not generally be considered Medicare telehealth services as defined under 1834M. As such, they are paid under the same conditions as in-person physician services. So fast forward, final rule comes out that year, and they actually make a payment available for an existing code that wasn't necessarily a code for remote monitoring. It's really for the collection and interpretation of physiologic data, but that was the beginning of it. And in that rule, they basically say, we are aware that AMA is working on codes on remote monitoring. We're eagerly looking forward to seeing what AMA creates. At this point, I'll pause for 1 second and just remind everybody that, we're going to be talking about CPT codes. CPT, our current procedural terminology, it's a code set, it's a nomenclature, it's actually owned, maintained, and administered by the American Medical Association. They have the copyright, and they also reserve all their rights on CPT. Just want to make sure that everybody realizes that it's a registered trademark of the American Medical Association. Therefore, go get your license. Go pay your 2 bits, get access to the code set. So at this point in the story, fast forward, AMA comes out with their remote physiologic monitoring and remote physiologic monitoring treatment management service codes, really the first very general codes on remote physiologic monitoring. That would be 99453, 99454, 99457, and 99458. And those codes go live in January of 2019. The following year, January 2020, an additional code goes live for each additional service. That's 99458. So I lumped it into the original family, but basically the original family are the first 3 codes, then 99458. And then a year later, the remote therapeutic monitoring codes, or actually 2 years later, the remote therapeutic monitoring codes go live, which is this most recent year, our year now, where we have remote therapeutic monitoring and remote therapeutic monitoring treatment management services. And very lastly, they've recently added or have signaled that they're going to be adding a cognitive behavioral therapy code, which is going to be going live in 1 year from now, January 2023. But that's really the history of how we landed from telehealth, which was not remote monitoring, all the way to now that we have several families that are remote monitoring related.
No, that's fantastic history. And so just to go back on something you said, you mentioned the Medicare physician fee schedule, you mentioned the therapeutic monitoring code. So from the last Medicare physician fee schedule that was published in November, it was early November sometime, I don't remember the last date, where these new codes were introduced. So could you explain what remote therapeutic monitoring is and how it differs from remote physiologic monitoring?
Yeah, so remote therapeutic monitoring is really, being able to monitor data on the signs, functions and systems that are related to therapy adherence and therapy response. And that's a little bit different than physiologic, because when you think of physiologic, when I say data monitored, that's data that's coming from a medical device, which is tracking adherence, response, or even subjective inputs that are being provided by a patient. And subjective inputs is really important for people to understand, because the idea here is that there is interactivity between the patient and the medical device, as opposed to the patient just transcribing information and then sending that directly to their provider. That's not what's intended through subjective inputs by the patient. It's a little bit different than the remote physiologic monitoring codes, because physiologic monitors are really our medical devices, which actually track physiologic parameters through a signal acquisition system, whether in the body or on the body. A physiologic element is something that's created or generated by the body. When you think of something that's therapeutic, it's really the response of the body to something that's being administered. Great example is Propeller. There is a sensor that's hardware, but the hardware is really tracking usage of a rescue inhaler, as well as environmental information that's being correlated through the medical device solution, the app. And it's giving that contextual, very important clinically contextual data that's relevant to this person's particular needs. So that's really kind of the difference that I see between therapeutic and physiologic.
That's a great background. And so with all this activity, a question that comes to mind, Meredith, is what are the benefits of remote monitoring that have been demonstrated so far? Maybe you can walk us through some of that, which I think sort of goes into some of the sort of coding evolution that Jaren was talking about.
Sure. Yeah, we've definitely seen promising outcomes associated with Propeller's digital health interventions over the last decade or so. And Propeller has now published almost 50 peer-reviewed publications exploring the outcomes and insights and in studies in many different settings and clinics and patient populations. So I'd refer you to the website to dig into some of those studies. But before I talk about the specific outcomes, I thought it might be helpful just to take a moment to describe how Propeller works. I think Jaren initially brought it up, but in this context of RTM. So Propeller is a digital platform focused on the care of respiratory diseases, so asthma and COPD, and really at the core are a suite of digital sensors that fit onto inhaled medications for asthma and COPD. So those include both the controller medications that patients usually take on a regular basis to maintain control of their disease, and then also rescue medications, which are more typically used as needed for relief from symptoms. And so the sensors are Bluetooth enabled and can collect the date, time, and the number of puffs. And then when paired with a smartphone, we also can collect the location of use. And so I think that helps us to add in that environmental context that Jaren had mentioned. So the purpose of that information is then to provide that back to patients via an app. So sending medication reminders, trends, and providing guidelines-based education. But then also with a patient's permission, sharing that data with their clinical care team, who can use that data to inform treatment plans, make medication adjustments as necessary, and enable early intervention if there's a worsening. And so another use of the data, we do use de-identified data to inform, aggregated to inform public health research. So we're looking into how geographic and temporal trends in respiratory symptoms can help us better understand how perhaps spikes in rescue medication use may across a whole population may be associated with air pollution, for example. So just to talk about outcomes to date, we've demonstrated significant improvements in asthma control, improved adherence to controller medications, reduced rescue medication use, and also importantly for patients, the increased frequency of symptom-free days. So that's a day without having to use their rescue inhaler. We've also seen on the healthcare resource utilization side a 53% reduction in ED visits for asthma and a 35% reduction in acute healthcare utilization for COPD. And also high patient satisfaction and improved self-reported productivity as well. So people being able to do the activities of their daily lives with less restrictions. And thinking specifically about older adults and Propeller, we've seen similar outcomes. So we've seen a doubling of those symptom-free days, as well as we actually see the highest controller medication adherence among those over 60 years old in both asthma and COPD. And then regardless of education and income of users, we've seen trends are really seeing similar improvements over the first 90 days in rescue medication use improvement. So again, I think it's what the kind of secret for the recipe for success there is what I mentioned earlier as well. They're really that combination of the technology and the clinical oversight. So eliminating no burdensome record keeping on the patient side, and then also the clinical team being able to use that information to really inform their treatment and interventions.
Well, that's great data on outcomes, but unfortunately in healthcare, every time we talk about sort of great and positive news, we also have to talk about barriers, right? And so I'm wondering if what has Propeller seen as some of the barriers and resistance to patient adoption of digital health technology? And I guess a corollary to that is how should digital health programs be structured to overcome some of these hurdles?
Sure. Yeah, there's definitely still work to be done for digital health in general, really with the goal of increased accessibility and usability, effectiveness and scale as well for diverse users. But Propeller has now implemented over 80 different programs, over 140,000 patients with really different program structures, different partners, different settings. And so we have had a lot of learnings over the past decade. And there are still some barriers for patients, I think, for digital health companies in general, and also for providers and at the policy level too. So just to name a couple of those, I mean, patients can face challenges in terms of limited health and digital literacy, broadband access, lack of smartphone ownership, which there are tech ways to get around that in terms of using hubs, like I mentioned earlier. But also, patients can have concerns around data privacy. And I think also recognizing the social determinants of health at play in their lives that make managing a chronic disease more challenging. I think digital health companies really need to recognize those issues and focus on usability and accessibility. So keeping things really easy to use and simple, using 4th, 5th grade reading levels and without technical jargon, large fonts and visuals, and then making sure information is culturally relevant as well. And to do so, I think there are some ways in terms of emphasizing user focus groups and interviews and diverse user testing, really before, during, and then after the product development process is really critical. And that's where I think the research evaluation comes in too. On the provider side, I think, obviously providers are very limited in terms of the time in the visits. And so that can be a challenge, but they really are such a critical resource to help build patient awareness and adoption of digital health. To do so, I think we really need to focus on building trust and comfort between the providers and the digital health platforms. And that can be done by having a really strong evidence base, by developing good working relationships, and then also really focusing on training. From an implementation perspective, so we've learned quite a bit about how to set up a program for success, especially within kind of underserved or vulnerable populations. We have numerous examples within Propeller about where, again, when the technology and the clinical care layer are combined, that's where we see the strongest outcomes. So we see better retention, we see better adherence, and we also see reduced utilization and high patient satisfaction. One example in COPD, and we had a program in Kentucky where there were physicians and respiratory therapists who were monitoring 190 dual eligible patients with their COPD and outreaching to them when they saw an increase in rescue medication use, and then bringing them in for a clinic visit as necessary. And we did see excellent outcomes and retention there with a significant reduction in rescue medication use. So that's one example in an older population.
That's great. And Carlos, I'm going to turn over to you. So Meredith was talking about providers and some of the barriers providers have to overcome. Sort of taking a step back from the physician perspective, have you seen physician attitudes towards remote monitoring change over the last few years or shift?
We have. I have, but I think the industry has in general. And it's been a couple of things at play here. We obviously can't ignore the effects of the pandemic. And I think obviously different than remote physiologic or remote therapeutic monitoring, just the opening up of telehealth services in general raised the awareness, I think, not just of the public, but also of physicians physician practices, other clinicians and other practitioners, because it gave them an opportunity to still connect with patients when they were isolated, especially in the early days of the pandemic. Using a very specific example, early in the pandemic, CMS waived the necessity for a sleep test to get a prescription for CPAP if you have sleep apnea. They allowed, during the early days of the pandemic, to just do a prescription by history and physical, and you could do it by telehealth. And I was on a webinar, early days of the pandemic. It was a joint Harvard-Yale sleep medicine webinar. And the physicians on there who were in practice saying, I agree, 80% of the time I'm fully comfortable doing this. And so it started opening the eyes in that specific example, but across all of medicine, that we can do things to connect with patients even when they're not in front of us. And so the concept of telehealth opened their eyes to, if I could get a little bit more data, if I could get a little bit more information, these interactions would be much more meaningful. And so when you think about sort of the future perfect world of digital health, where patients and their homes are connected, and a doctor's office, a healthcare system is perfectly prepared to ingest the data and do something with it. The barriers are what you would expect. On the institutional side, on the physician and the office side, it's making sure that you build this into your workflow. You can't just have this as another thing you do on top of, because it will be ignored. It won't be a part of the standard workflow. I'll give you a personal example. So my primary care physician uses an app. They're on the Epic system, and they use the MyChart app through Epic, but they've branded it for themselves. They push us as patients to use the messaging feature because they have staffed up in a way so that they've got medical assistants who monitor the email and the chat all the time, and their goal is to respond within 2 hours. They've changed their workflow. They've changed the way they think about connecting with patients outside of regular channels. So when you start to do that in your practice, when you say, okay, gosh, I have a respiratory care practice, and I have patients with asthma, and they're on a platform like Propeller, or I've got patients with sleep apnea, and I'm monitoring their CPAP therapy remotely, how do I build an office practice? How do I build a workflow around this so it becomes part of what I do? So as the coding and the billing catches up, you have built a system of practice that reimburses you for the work that you've now, sort of refactored yourself around. So that's the institutional barriers. Really, is the biggest one, is being prepared. The barriers that come from the patient side, something I alluded to before about data and information. Healthcare is notoriously data rich and information poor. And if you tell the typical primary care or even specialist, we're going to just start sending you millions of data points every week from every one of your patients, figure out what to do with it, they're going to be drowning. It'll be similar to, and probably even worse than, the complaints you hear today from patients saying, my doctor's face is buried in that laptop. They talk to me for a second, and then they look down, and they're more engaged with their EHR than they are with their patient. If we do this right, if we convert all of the data, the raw data, through the software or algorithms or systems or devices or sensors, whatever it is that the vendors, that the innovators need to do, so that when that doctor, nurse, medical assistant, physician assistant opens up whatever platform, they're presented with the most relevant, timely, actionable.
Okay, I think we may have lost Carlos. The vagaries of technology. We'll give him a second to come back on.
I turned off my video. Can you hear me?
Yeah, now we can hear you. Yeah.
All right, I turned off my video. I just got a little pop-up that said my internet connection is unstable. So there may be something going on in my neighborhood.
Not a problem.
Yeah, sorry about that. So as I was saying, as we build the infrastructure for a future where patients and their therapies and their lives are connected in a way that they participate in the healthcare system, no matter where they happen to be, it's incumbent on all of us to build a system that behaves the way consumers are expecting. But a bit of a personal anecdote. If you may have noticed a few minutes ago, I might have been looking off to the side. I actually just sent my mother a text. My 81-year-old mother is in the process of taking my 82-year-old dad in half an hour for chemotherapy. So they are in their 80s, they're elderly, one of them is sick, and they're dealing with all of the things that Meredith talked about: access, mobility, social isolation, all of those things. They live minutes away from me, and I can still see how isolated they feel at times. We have to address all of these things. Someone like my mother needs to be able to pick up a smartphone or speak into a smart speaker and interact with the healthcare system as easily as she does with the Amazon app to order her groceries, or as our generations get older, as easily as we do with apps like TikTok. It should be brainless, mindless, to be able to just go in and say, I need to connect with my doctor, I need to refill a prescription. They need to know that I had a difficult night or a difficult day. We are starting to put together the pieces, and if we think about this and we build it deliberately, we can have a learning healthcare system in the future that takes advantage of the fact that we're pushing these responsibilities on patients without equipping them completely for this new reality. We, as an industry, as a field, as clinicians, as innovators, need to ensure that patients come along for the ride. If we do this right, we give access to all of the disadvantaged socioeconomic groups, not just the elderly. If we build a digital health ecosystem that allows people the access they deserve and the ability to monitor the therapy that they need.
Yeah, I'm going to ask you about clinics in a moment, but your comments brought up an issue for me that I've been thinking about a little bit. Just wanted your reaction. You talked about the pandemic and how it's fueled a lot of innovation and a lot of sort of shifts in attitude. What happens once COVID recedes more and more in memory, 1, 2, 3 years down the road? Is there a chance that we could go back to the way things were?
That's a great question. And you know what? I see Jaron nodding because he probably has some insights to this as well, but I'll give it the first answer. There is. And you know what? I think back to, it's not a perfect analogy, so forgive me, but 9/11, how people were so afraid to just go near an airport or get on an airplane. And within 2 or 3 years, we actually had more planes in the air and more people flying than ever in human history. We do have short memories and short attention spans, and we tend to go back to what we are familiar with. You can see whenever there's a break in the pandemic, it opens up a little before Delta, before Omicron, people go crazy. They want to travel, they want to get out. We want our lives to get back, but we also need to ensure that we don't go backwards in the gains that we've made. We've made some tremendous gains, for example, in the way we work, hybrid working, Zoom. Even when Wi-Fi doesn't work perfectly, I was able to turn off the video. We figured it out. We've made tremendous strides. We cannot go back. So what I would say is working with the academic and the clinical societies, working with regulators and members of government to ensure that the work that was done under the guise of the emergency, not the guise, but under the auspices of the emergency, the good ones we keep, the ones that were imperfect, we make them better. And the ones that didn't work, we learn from them and we move on. But we can't relax. We can't just crack open the door to digital health because of the pandemic and then let it slowly swing back closed because of neglect or momentum or inertia. So I would say it's going to require a lot of work from patients, from providers, from the innovators in industry, and from regulators to make this sticky and make it work. It will make our healthcare system better. It will make people healthier. It will make our healthcare system more efficient. And hopefully we don't go broke in the process. We actually have a system that will persist and become sustainable because we've made it better and economically more efficient.
Jaron, did you want to weigh in?
Sure. I think Carlos hit it on the head that we tend to have a short memory and tend to go back to comfortable things. The problem with telehealth is that where it came from, as I was trying to describe earlier, is a very arduous place, and it's not easy. All of the payment rules around telehealth make it very, very specific. During the public health emergency, because of waiver authorities, that came not only through the invocation of the public health emergency through the Secretary of HHS, but also through the determination of a Stafford Act that was, a presidential order. This gets reauthorized every 60 days, I believe, or 90 days. We still are currently under the public health emergency, but the waivers, really came about through a number of additional legislative enactments, to really give us where we are now with waiver. And right now, it is very permissible for telehealth, and including for other areas that are specific to even remote monitoring. 16 days of data requirement is gone for those with acute conditions that either have COVID-like symptoms or have been diagnosed with COVID. That's a big deal. The ability to exercise enforcement discretion on copays during the public health emergency for telehealth as well as for remote monitoring. That one's a really, really big deal. New and emerging technologies do require copay, just like any other technology when you're not under waiver authority. But now that we are, that's really very helpful for that demographic, of the population, which, really is financially constrained. Those types of things will come back very quickly once all of the waivers disappear. And, that's where we're headed toward. The most recent budget enactment had language in it which will extend telehealth waivers for another 150 days, I believe. But beyond that, we don't have anything. There is no fallback. The sunset, unfortunately, goes down really quickly, and all of these very arduous restrictions on telehealth, virtual care, and even remote monitoring will resume. And that's tough. That's going to be a tough place to be at. So, I know that there are a lot of stakeholders out there and a lot of organizations, but those listening in, whether you're providers or work for institutions, et cetera, let your voices be heard. Congress does listen to you, and this is all going to be congressional. CMS has done a fantastic job of trying to use its regulatory authority to enact some of these permissions. Same with OIG, but beyond that, a lot of this is rooted in congressional stuff. So let Congress hear from you. I think it's a really important thing. So I'm glad you brought it up. Thanks.
Sure. So I just want to go back to remote monitoring for a second, and then we'll get back to some of these other issues. So back to you, Carlos. In terms of remote monitoring and success from clinics, what do clinics need to do to succeed with remote monitoring? Are there some best practices you think clinics could adhere?
Yeah, and some of it is what I alluded to earlier. And first of all, I turned my video off again, so hopefully you can hear me okay. I noticed a little choppiness again. So what I was saying earlier about, building your workflow in your clinic around this, make this a part of how you practice medicine and nursing for your patients. Make them aware of what exists and what help you can provide for them. There are, for example, I referred to the MyChart app that I use with my own primary care. They provide help, and they have online tutorials to help people figure out how to get on and do their video visits and things like that. I also think that understanding the state of the art, there's a question in the Q&A that I can actually address a little bit here, talking about the remote therapeutic monitoring codes for respiratory care. What types of actionable information can a patient act upon? When a clinic understands the entire pathway for the patient, they can help the patients understand how valuable this can be. And I'll give you a very specific example. So sleep apnea devices, CPAP machines, are the most widely connected medical devices on the planet. It's really interesting, but very quietly, that industry, and full disclosure, ResMed is the largest player in that industry. Over the last 7 or 8 years, we've collected tens of millions of devices in the world that are now connected to the cloud and streaming information daily. And what we have shown through peer-reviewed research that's published, people who use a CPAP device have about the same adherence as medication adherence in general, 55%. If the device is connected and the provider can see how you're doing, your adherence to CPAP therapy jumps up to 73%. If the patient downloads an app and the app shows them every morning how well they did on their therapy, and it's just a big number in a circle with some details, but everyone just looks at that number, how close to 100 did I get? adherence to CPAP therapy jumps to 86%. So we know when patients are engaged and when providers are engaged with connected care that surfaces just the important information. There's another question in there about, are we ready to deal with all of the data? No, we're ready to deal with actionable information. So you give a patient an app with one big number and they can act on it, adherence to their therapy, in this example, jumps from 55% to 86%. It's an almost unimaginable jump. So we know that it will work if clinics build out the workflow, they connect with patients properly, take advantage of the technology that's available, and again, focus on the actionable information that makes a difference for that patient and makes a difference for your care.
Yeah, excellent. And just to toggle back a little bit, I will get to some of the questions on the Q&A, I promise. There's some good questions in there. But I want to sort of, we've talked about coding, we've talked about outcomes, we've talked about the role the pandemic has played. Now I want to sort of turn into the future and talk about what is the future remote monitoring, particularly as it relates to health equity and diversity. And Meredith, why don't you get us started on this, and then I'll go around to the other panels to get their thoughts.
Sure. Yeah, I am quite excited about the future, where we're going in the future of digital health, especially as we scale and grow and get wider adoption. And definitely there's still a lot more to learn in terms of how to implement in the most successful way. But there's really great promise, I think, to be part of the approach to addressing disparities. I think about what are the main mechanisms by which digital health really aspires to support patients of all different types. And I think they really come down to supporting patient management, including specific self-management, including specifically medication adherence, trying to kind of build that ability for the patient-provider communication. So, and through that improved communication, building trust as well. I think having the information that providers can use to then target their interventions to patient-specific needs and really pulling in a shared decision-making approach. And then enabling earlier intervention at the first signs of worsening. I think that's a really important one. But I think that the data that's going to be generated can really help increase the quality of the clinical research as well as the public health research that we're doing. And, addressing disparities, obviously, it's going to take a very collaborative effort from stakeholders across healthcare and outside of healthcare as well. I think digital health companies have a really important opportunity to be thought leaders and really push the boundaries here. ResMed and Propeller have been partnering across the industries with AdvaMed and MedTech Color and CTA and the HEAL Coalition. And from my perspective in the research world, I think research has a really important role to play. From that research perspective, Propeller and ResMed are specifically doing some things in research. So trying to increase racial and ethnic representation in our studies and our usability in our clinical studies, engaging diverse patients in focus groups and patient advisory boards, really to hear more about their own patient journeys and experiences. And then ensuring that our research is evaluating how outcomes with these digital health solutions may vary by subgroups of patients. So by age or by race, ethnicity, by gender, and by socioeconomic status. And I think that through that process, we can develop real world evidence on disparities among patients in asthma, COPD, and sleep apnea, to what Carlos mentioned before. And I think that can both raise an awareness internally for product development as well as externally. And just one last point that I'm really passionate about it is, and I think I see so much potential for digital health, which is in addressing and greater recognition of the social determinants of health in patients' lives. As everybody is familiar, but only about 20% of our health outcomes are really determined by that clinical care that we receive. The rest, that outsized influence, is really the social, environmental, and behavioral determinants at play in our lives. And so I think digital health, because it's really collecting health outcomes in the context of our daily lives. We have, in Propeller's case, rescue medication use in the place and at the time and in the context of a patient's daily life. I think that really provides us with the data to better understand how the determinants in their lives are influencing their outcomes and how we could potentially screen for those social determinants. flag them, better understand them, and then ultimately, years down the road, we can really use that information through research to help aim to prevent the upstream drivers of disease. So that's my excited vision for the future.
Love the passion, and great point on social determinants. And we can maybe, if we have some time, sort of go back to that point. Jaren.
Yeah, so I'm the regulatory guy, so I look at everything through the lens of what is government doing on policy, regulations, even law. And one way to look at this is, where have we been, right? Prior to 2015, when it comes to remote monitoring, it was almost non-existent, other than cardiovascular, and since then, given the fact that it was, put into, like I mentioned, this report to, the requisition by Congress, that's only been 7 years. Look at what we've accomplished. We've accomplished coding. The American Medical Association has, obviously I'm impartial because I'm a part of that, but, they've done a great job to take digital health very seriously, to integrate digital health, not only as a concept, but also trying to get out tools to the provider community for people to understand how to use digital health tools and understand coding. And then on the coverage and payment side, I think CMS has done an incredible job since really getting involved in the summer of 2017 in anticipation of the fee schedule in 2018. That's 4 years ago, to really open up coverage and payment and even adoption of new codes, whether the remote physiologic monitoring codes or the remote therapeutic monitoring codes, in addition to really focusing on non-face-to-face services via existing codes through care management services, whether transitional care management or complex chronic care management or chronic care management, behavioral health integration, and even creating a whole new set, a whole new family under those codes for principal care management services, in addition to virtual care services that are, communication technology-based services. That's a lot. That's a lot that's been done. Now, obviously, I hope that more gets done. And, to that, I look at, where is the collective head of government these days? And you see a lot, you see a lot being done on the executive level, through management, personnel decisions to hire people that are specific to AI. You see that in RFIs issued by the White House and OSTP. You see that on the agency level. Look at FDA. FDA has taken AI very, very seriously. They've got, great staff that's working on artificial intelligence, having churned out a number of different white papers. They've had showcases, most recently just a couple of weeks ago with Duke Margolis. There will be forthcoming, they've mentioned that they're going to be working on guidance specifically on AI. All of that is a lot. And then in addition, you go somewhere like CMS in the most recent physician fee schedule. Again, this is the annual rule that's put out for Medicare Part B physician services, and really the payment regulations, the rules, regulations, and policies behind Medicare payment for doctor services. There was a giant RFI that was nestled within the fee schedule last year that was specific to artificial intelligence, in addition to raising all of the questions on diversity, equity, inclusivity, and how that affects payments and payments going forward, and AI. And, I haven't really gotten to talk about the AI issue, but it really is something that falls back on even something like remote therapeutic monitoring. Artificial intelligence for, the greater, best purpose of it, a lot of it's going to be rooted in software, and that software is a medical device. And software is something that CMS does not pay for. Making a very long story short, under the practice expense for medical equipment and supplies, or indirect services that's, or parts of the service that CMS doesn't pay for, computer software is considered indirect practice expense and something that they don't pay for. And that's regardless of whether it's off-the-shelf software, like the stuff that goes into your laptop, which is really just to run your laptop, or if it's software as a medical device. And that's a really big deal. I mean, in fact, last year, speaking of the remote therapeutic monitoring codes, in the discussion for CPT code 98976, which is a respiratory systems monitoring supply code, CMS very specifically said, we noted that the only input to the CPT code 98976 is a monthly fee of $25, which would not be paid as a direct cost under the physician fee schedule. Historically, we have considered most computer software and associated licensing fees to be indirect costs. And they discussed this in this RFI that was included in the physician fee schedule. And it's something that they are really taking very seriously. They have an entire group within CMS that's working on trying to advance and modernize their practice expense methodology. It's all very public. They've actually acquired the services of Rand Corporation to help them with their PE methodology. AMA spoke at a showcase that they had over the summer. Again, kudos to the agency because they're moving nimbly in the direction of really advancing healthcare and modernizing it. So, to me, those are my tea leaves. That's what I look at. In the last 7 years, we've come a very long way. But I think that, the next 7 years are going to be even more promising because of how far we've gotten.
Yeah, and I also think to add to Jaren's points, this administration really has a strong interest in promoting health equity. It's one of the pillars they have as part of their healthcare sort of policy priorities. And so at least this administration is paying attention very closely to health equity. And it's up to us to ensure that they understand the digital health aspect of it and how it intersects with health equity. And Carlos, you sort of addressed the question I asked about the future. So I want to save some time for some Q&A. And actually, I'm going to direct this question to you, Carlos. One of our audience members said, with the way things are moving, we risk having 50 devices at home for different monitoring purposes. How will this, quote unquote, clean up itself over time?
It's a great question. And I don't know that we have the answers just yet, but you're absolutely right. I mean, if you search on, the Apple or Google app stores for diabetes, for example, thousands of apps pop up. Which of them are legit, which of them are, something you should be paying attention to. Go beyond the apps, then it's like, well, I've got a Fitbit. Oh, but then I've got this connected medical device. And that Carlos dude just told me my CPAP device is connected too. And you're absolutely right. We are in danger of a proliferation of devices, a proliferation of software platforms that aren't always as interoperable as we would like, and don't always actually do what they're advertised to do, because there's, like I said, there's a lot out there. And for every Propeller-like platform that is legit and clinical and medical, there are probably, dozens and dozens of other apps or platforms that are more consumer or more health focused. And there's a subtlety there that people, don't quite understand. And so I don't know that we have a really good answer. There's going to continue to be a little bit of proliferation, I think, in the near future of apps, of connected devices, of the potential for, your patient to look like a cyborg with so many things connected and all these data streams. At the end of the day, though, the way I look at technology, it has to be simple, ubiquitous, and consolidated into as few platforms as possible. For those of you who are Apple people, for example, Apple has built this ecosystem where if you've got one of their phones and their watch and their tablet, and it all works better together. Medicine needs to get to a point when digital health matures that we treat it the way we're starting to treat the EHR. It is an important, vital part of our healthcare system that needs to be interoperable, that needs to be understandable, and cannot proliferate. But how that weeding out is going to happen, I think it's going to be a combination of sort of the natural market forces. The little startups and the apps that go nowhere eventually will disappear. The apps and the platforms that are connected to meaningful clinical and economic outcomes and benefits for patients and providers in the health system will do well. And then I guess the wild card will be similar to the EHR. Will we have a meaningful use-like program come down from the government that funds things in such a way that we end up with just a few dominant platforms or a few well-integrated platforms? I I know some people are critical of how meaningful you shook out, because we went from an EHR market that had dozens and dozens of viable competitors to one that has just a few. And I don't know if that's the right direction for digital health, but there will be a consolidation. There will be a reckoning. It's going to take a variety of forces from a variety of directions to engineer what that looks like.
Meredith, you want to weigh in?
I know that challenge of multiple devices at home is going to be a big one, and definitely need to focus on seamless data collection and syncing. So there's the tech piece of it. I think education really about what devices are used for what and when to use them. And then I think also to my earlier points about the combination of tech and care. So some sort of layer of oversight, a coach, for example, who could help resolve any tech issues, I think will be critical there too.
Great. I think we have time for one more question. I'm going to direct it to Jaren. And before I ask you this question, Jaren, just again, a repeat of the disclaimer. This is not billing or coding advice. But the question from one of our audience members is, could software-only services, for example, a mobile app, be part of therapeutic monitoring?
I think it depends. You have to look at, the two different sets within the code family that we're discussing. And thank you for the proviso. Again, not billing advice, go seek, a billing consultant or an attorney. This is really for contextual purposes. But when you think of the remote therapeutic monitoring codes, it's really two sets of codes within the single family. One is remote therapeutic monitoring, which is really supply. That's PE only. Hint, hint, I just talked about PE. The other side is work and PE and malpractice. The first side actually does include malpractice as well, but there's no work. Work means the provider work. So when you think about, what these codes are derived of, there are foundational components of each code. But under the PE side, it's important to understand that there are direct expenses which are paid for by CMS. And that includes things like medical supplies, medical equipment, et cetera. But then there are indirect expenses which CMS doesn't pay for, things like the telecommunications expenses or, keeping the lights on in the office or computer software. But the computer software is really interesting because computer software could also be software as a medical device. They don't pay for that. So you have to kind of peel the onion that way. Then on the other side, on the work side, if a provider is utilizing, a device as defined by FDA, the PE side of that doesn't really apply to that specific device, right? Because it's a little bit different. This is more now the work that the provider is doing, and they're relying on a medical device. These are areas that are very ambiguous. They're very unclear. We haven't gotten clarity from CMS as to where they lie on this or other insurers out there. So, take a look at this area, follow this area. If you have a voice, let it be heard. The physician fee schedule not usually by law, has to take comments from the public. So when the next fee schedule comes out, which is July of this year, put your comments forward if you feel strongly one way or the other. If in fact, the clarification comes down and it doesn't sit well with you, or if you want to expand on it. That's the way I would look at that.
Excellent. And I think on that, we're going to end. I want to thank the audience for the wonderful engagement. I've seen a tremendous engagement on the chat, for all your questions and for joining us. I want to thank our wonderful panelists, and have a great, wonderful rest of the week. Thank you.
Thank you to Renee and all of our speakers. Please visit our website at hlth.com to catch up on all Health GoLIVE webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.